If you enjoy listening to clinical conversations, why not become a member of the Royal College of Physicians of Edinburgh? Our membership provides you with access to the RCPE educational portal, the live evening medical updates, and you have options to view the symposia both in person or online. If you would like to learn more about this, please go to the Royal College of Physicians of Edinburgh website. Hello everyone, and welcome to another episode of Clinical Conversations brought to you by the Royal College of Physicians of Edinburgh Trainees and Members Committee. My name's Marilena Giannoudi and I am on the Trainees and Members Committee, and today I'm delighted to be joined by Dr Sean Ninan, who is a geriatrics consultant at Leeds Teaching Hospitals and the clinical lead for Dementia and Delirium. So welcome Dr Ninan.
Thank you very much.
Thank you so much for joining me. And today we'll be talking about frailty for the non-specialist. So I guess the most fitting question will be, what is frailty?
People sometimes struggle with defining frailty, and it is a bit knotty, so I'm going to talk about it in a couple of different ways. Frailty is a long-term condition where multiple systems in your body are declining. So that means you've got kidneys that weren't what they used to be, a heart that wasn't what it used to be, maybe a brain that wasn't what it used to be. And you've got multiple things wrong with you that accumulate, produce this syndrome where you might appear physically tired, physically weak, might be generally slowed down. Often people are quite thin. So that's kind of how people kind of imagine what a person with frailty to look like. But what it means if you've got lots of things wrong with you is that you're at higher risk to bad things happening compared to people of the same age. So it's a way of describing the difference in risk that exists between people of the same age. So some people who are 85 years old live an independent life and don't need any help with anything, maybe avoid seeing doctors, maybe avoid going to hospitals because they're quite healthy, whereas other people have lots of things wrong with them, maybe need help living their everyday life and tend to be in and out of hospital, and that group of people is more likely to have frailty. If you have frailty, you're also more likely to get ill with little things happening to you. So you or I, if we get a cough or a cold, fingers crossed, it doesn't bother us too much and we're still able to go about our daily lives. Whereas an older person who picks up a minor infection or a minor problem like constipation or dehydration, sometimes that's enough to send them to bed and sometimes enough to send them into hospital. So this idea that you're vulnerable to minor stresses, you're not able to maintain homeostasis is what people talk about in frailty, and little things can make you seemingly dramatically poorly and it can take you a long time to recover and maybe you won't recover at all. So lots of things wrong with you, higher risk, bad things happening when they shouldn't be.
And so how do we actually identify it? You mentioned a lot about, activities of daily living and what someone can do as a potential marker of that. Is that the only way that we can identify frailty, or are there other measures as well?
So I think before talking about identifying frailty, it's just worth knowing the two models of frailty, because I think that will help talk about the two ways of identifying frailty. So there's two main models of frailty, and one of them is about what people look like, and that's the phenotype models. Linda Fried was a researcher who actually investigated cardiovascular database, and she found that a certain set of characteristics predicted bad outcomes. And these things were unintended weight loss, fatigue, being physically weak. So they measured grip strength. So you'll often find that frailty research often talks about grip strength, a slow walking speed, and reduced levels of activity. So they said if you've got 3 out of these 5 things, then you're likely to have frailty. 1 or 2, you're said to have pre-frailty. So that's a kind of physical description of what someone looks like. Someone who's tired all the time, not doing very much, walking slowly, physically weak. And the other major model was something called the accumulation of deficits model. That's by Rockwood. People might have heard about in the clinical frailty scale. And Rockwood basically said that the more things that you have wrong with you, the higher your risk of adverse outcomes, the higher the degree of frailty that you have. And people often think about, having lots of comorbidities. And what Rockwood looked at was it wasn't just the comorbidities that put you at higher risk, but certain symptoms, certain exam findings, certain lab values, certain difficulties with activities of daily living. So construct a model that maybe there might be 20 things in this model. And if you had 10 out of these things, you had a frailty index of 0.5. And if you had 5, you had a frailty index of 0.25. So the second kind of major model of frailty is about understanding that you have more things wrong with you. So there's what you look like and you have more things wrong with you. And I guess the reason worth talking about that is when we talk about identifying frailty, the two major things that people are used to in the UK look at those things. So the first kind of way that people might be used to is something called the Electronic Frailty Index. That was developed by geriatricians just down the road from me in Bradford. And they looked at a frailty index like I've just described. So looking at the number of things wrong with you. But the difference was that rather than having this index being performed after a comprehensive review by a geriatrician, they just looked at things in the GP database. So they could just interrogate the GP database and come out with a score of the number of things wrong with you. And the higher your frailty index, the worse your outcomes of various things. And then the other model is the clinical frailty scale. That's something that people, I think, are becoming increasingly familiar with. And that looks a bit more like problems with ADLs, which I think is what you're describing. So on the one hand, you've got people with clinical frailty score of 1, which would be like my dad at 70 years old, who still goes to the gym every day. And then a clinical frailty score of 7 is somebody who needs help on a daily basis. So needs help getting in and out of bed, washing and dressing, toileting, meals, most of those things. So in terms of identifying frailty, those are the two main models. The EFI I'd recommend as a kind of screening tool for a population. If you're a primary care practice trying to identify where your severely frail patients were, you'd use that to start off with. But to kind of describe someone on an individual level, what their level of frailty is, we'd use a clinical frailty scale.
And in your experience, what do you think people struggle with the most when they think about frailty and identifying frailty?
So I think a couple of things. So actually, I think sometimes we've not made the case for why it's valuable very clear. And I might talk about that in a minute. But in terms of actually scoring it, I think in hospitals, certainly people have a problem because we tend to see people at their worst. So when we see somebody ill in bed, with a pneumonia or a heart attack, in their night clothes and on oxygen and drips, it's quite hard to imagine. Some of those people may have been driving and independent before they came into hospital, because you kind of look at someone and think, they look frail. So I think the thing to get used to is get used to the idea of asking what people were like before they got ill. Typically, we say 2 weeks before acute illness, and asking in a bit of detail about activities of daily living. So again, I think we're used to kind of saying that someone's independent with ADLs or doesn't need any help, whereas some of those people who are independent with ADLs, if you haven't asked enough questions, you might not know that they need help with, cooking or cleaning or shopping. And that, to me, identifies somebody who's at least a clinical frailty score of 5. So I think two things that people struggle with in the clinical frailty score is understanding that we score them at their usual selves, not at the kind of moment of weakness in A&E resus. And secondly, just going into that extra level of detail, at the kind of lower frailty scores, can you go for a long walk or exercise or manage your finances? The higher levels of frailty scores, asking about how they manage their household work and then their basic activities of daily living, like washing and dressing and toileting.
And you mentioned that we'll go on to why frailty is important. So I guess before we do that, who should we be thinking about asking these questions to? Because obviously different hospitals will have different cutoffs for what the geriatric population is like. From working on the acute medical ward, we would still have patients that are younger that would be classed as frail without us actually doing a formal frailty assessment. So who should we be having that alarm bell that this person needs a bit more of a formal frailty screen and thorough questioning, such as the ones that you've described to us?
Yeah, so in terms of an age cutoff, most of the evidence of interventions from frailty comes in over the 65s. So I'd recommend it for people over 65. Like you're saying, there's kind of increasing interest in kind of younger people with frailty or younger people at higher risk. From my point of view, as far as I understand, there isn't evidence base to kind of say that it can do the sort of things that we do with older people in people who are 50. So when I see somebody with frailty, most of the patients I look after are in their 80s. I'm looking for things like dementia and delirium. I'm thinking about things like continence. I'm thinking about, treatment escalation plans and the fact that maybe some higher levels of intervention in hospital might not be appropriate for some people because they will work. I'm thinking about the fact that medications like statins might not be relevant for people with a short life expectancy of 1 or 2 years. Those things don't automatically all translate to people who are like 55 and who might have lots of things wrong with them, but many still have a reasonable life expectancy. So it makes it a little bit harder. I think with those younger people, there's definitely something about kind of being holistic and patient-centered and thinking about what else is going on. But yeah, in over 65, there's evidence base for geriatric interventions.
And if we go back to what you said earlier, why is it important that we identify these people as soon as they come into hospital?
So I think the first thing is just about, on a very basic level, not writing off people because they're 85, because two 85-year-olds are different, and some 85-year-olds live an active life, and we should recognize that and understand kind of what we're aiming for. But equally, other people who are 70 or 75 might be severely frail or maybe closer to the end of their lives than we think that they are, purely based upon age. So it's a way of just understanding that you can't just judge somebody on age, and it gives you that extra piece of information about degree of risk. And risk is, I think, a really important thing to think about, because the higher degrees of frailty have higher degrees of risk. So they're more likely to be admitted to hospital, they're more likely to stay in hospital for longer, they're more likely to die, they're more likely to end up in a nursing home. So police need to be aware of that higher level of risk. And then beyond that, there's something about recognizing a different model of care. So if you have a 75-year-old person who's just got a pneumonia, is normally fit and active, doesn't have much else wrong with them, then you can just concentrate on treating a pneumonia. You can give oxygen and antibiotics, fluids, and think about what tests to do, and get them over to oral antibiotics and get them home as soon as possible. Whereas if you find a 75-year-old person with severe frailty with a pneumonia, it's more likely that they're going to have other things wrong with them at the same time. They're more likely to have delirium or immobility or polypharmacy. It is more likely that on day 3, when you switch them over to oral antibiotics as appropriate, somehow they're not ready to go home. And people who are inexperienced often kind of go discharge planning, physio OT, because that's what we might be used to. But actually what we need to be thinking about in those patients is, as well as the pneumonia, are they constipated? Are they eating and drinking well? Are we getting them out of bed? What are we doing to rehab them? Are they in urinary retention? Are some of these medications that normally cause benefit for patients maybe causing harm? They just need a kind of completely different way of thinking. You can't look after older people with frailty the same way that you can look after somebody who's fit.
And is there something in particular that us as junior doctors, if I can use that phrase, I know there are multiple phrases around for doctors in training, should be particularly looking out for, or should be alerting geriatricians to, for these patients?
So I think in terms of alerting geriatricians, it depends on the model of care in your hospital, because there are quite varying different numbers of geriatricians in different places. So Leeds, where we work, is one of the biggest geriatric departments in the country, and a large proportion of patients with frailty get looked after by geriatricians. Despite that, there are still huge numbers of people with frailty in the other specialties. And in other hospitals, quite a small proportion of patients with frailty get looked after by geriatricians, because they're simply smaller units. So I think that depends on your local frameworks. But in terms of what you should be looking out for, so I think on a basic level, you need to be thinking about what the GIRFT recommendations talk about. So I don't know if you've heard about the Get It Right First Time program, and they did one for geriatric medicine. So this is for the whole hospital, not just for the specialty. They said that as well as in use, we should be calculating a clinical frailty score and a 4AT for all older people. And I'd say that. So first of all, know your patient's level of frailty, so you know what you're aiming for, and screen for delirium. I'd say as you're seeing the patient, as well as checking the normal things like we do, like OBS and blood tests, I'd also be checking their mobility and comparing their current mobility to their normal mobility. That to me is as good as a CRP in terms of tracking someone's recovery from illness, or maybe even detecting acute illness. And then beyond that, I'd be thinking about things like nutrition, constipation, urinary retention, polypharmacy. The delirium kind of prevention guidance is probably as good a place as any to start in terms of basic geriatric care for the non-specialist. So I don't know if you've heard of a mnemonic called pinch me, which is sometimes used for delirium, but that's meant to be used if people have a delirium or a high risk of delirium. And that stands for pain, infection, nutrition, constipation or catheter, hydration, medications and environment. That's as good as a place as any to start off in terms of thinking of looking what else you can do for this patient with frailty.
Okay. And with regards to the 4AT and the CFS that we should be doing as part of these guidelines, I assume that the clinical frailty score we do at the time of admission, and that's kind of what we work with. But in my limited experience, patients can develop delirium kind of later on in their admission. So how often should we be repeating the 4AT when we are reviewing these patients alongside, obviously, the new score that you mentioned? Is it just when we see a clinical change, or should we actually be doing it more regularly than that?
It's recommended when there's a clinical change, so kind of on admission to hospital, and when there's a clinical change such that you'd suspect delirium. And the reason for that is that there might be a practice effect to asking the same questions, on a shift by shift basis. So in my personal practice, bearing in mind I'm a geriatrician on a ward with loads of people with delirium or dementia, I tend to do it a bit more regularly than is recommended. So I would do it kind of when I think that the 480 score doesn't quite reflect what they were before. So if I see someone's improving or someone's deteriorating, I'll repeat it kind of semi-regularly. But even as a delirium lead for the hospital, I've not set guidance for other people to do that because there's no kind of clear evidence that you should be repeating the 480 on a frequent interval. It's more that you should be thinking, is this person more confused than they used to be? And if so, we should repeat the 480 at that point.
Great, thank you. And would it be possible if you could just maybe talk us through the comprehensive geriatric assessment toolkit?
Yeah, so comprehensive geriatric assessment is what geriatricians do on geriatric wards when we're looking after older people with frailty. And that's, a structured assessment led by someone with expertise in managing frailty and its syndrome. So typically, I've traditionally been a geriatrician, but increasingly we are getting more specialists in frailty from different roles. And particularly, in community roles, there are kind of specialist frailty practitioners. So there's a kind of specialized unit with a leader in geriatrics that works as part of an MDT to assess not only their acute medical issues, but consistently and systematically look at their comorbidities, their physical function, compare changes in mobility, think about cognition, think about nutrition, think about continence, think about rehab goals, and think about treatment escalation goals. And we do that kind of thinking about person's kind of preferences and values are. So I sometimes see people who are close to the end of their life and they clearly don't want any further treatment. We stop things. Otherwise, there are other people who seem close to the end of their life, but quite happy for us to continue treatment. So something individualized in the way that we provide care. So yeah, we're doing all these structured reviews. There's a specialist leading it. There's an MDT used to looking after people who have frailty. And we kind of work together to come up with a plan for it. So on my ward, I'd be doing my assessment, therapists do their assessment, the nurses make their observations about what's going on with the person, the pharmacist is saying, should you really have started that medication or should we stop that medication? We meet on a daily basis as an MDT to talk about the individual issues that our patients have. And we've got quite a structured way where we do that. So we talk about acute issues, function on the ward right now, kind of rehab goals, what do it take to get the patient out of hospital, and routinely look at things like CFS, 480 as we're looking after the patients. So yeah, that's in a nutshell.
Okay, thank you. And can I ask you another question of the role of the frailty unit and how that's different to inpatient geriatric assessment and treatment?
Yeah, so I guess acute frailty units have been in Leeds for a long time in terms of essentially the assessment unit for geriatrics. So it's about getting a lot of this stuff done at the front door straight away. So you're immediately thinking about things like respect discussions, thinking about whether someone needs to be admitted to hospital, thinking about how long they need to be or whether there are alternatives for them. And often in Leeds, we've got two different things. We've got a same-day emergency care unit where people might come and it's not clear that they definitely need to come into hospital and get assessed by a geriatric team there. We've got an admissions unit where people come if they're likely to need to come into hospital. But what we can do from those places is also think about what other pathways that people have. So for some people, we could maybe send them straight to a rehab unit. And in these, our rehab units are largely staffed by geriatricians. For other people, we might send them home and maybe they don't need to come into hospital or maybe they need hospital level care at home. And again, we've got access to that. So we've got what's more commonly known as a virtual ward or virtual frailty unit, but we've got a home ward where people get the same kind of level of care as they do at hospital as they do at home. And then we've got access to other pathways. So thinking about support systems at home, whether that's therapy services or temporary step-up care at home. So frailty units are about kind of getting all the right assessments done at the right time and then deciding whether somebody's coming to hospital, in which case you've started all the right care, or then sending them to their appropriate destination based upon your expert knowledge of local systems. In Leeds, we're quite lucky in that we've got a range of options available to us.
So with the patients who you can treat via your virtual units, where it's hospital level care but at home, is that due to specific conditions that need to be met, specific diagnoses, or just the level of care that they actually require?
Yeah, so I guess every kind of virtual frailty unit will have its own criteria, but ours are broadly that an older person with frailty needs hospital level of care, but is somehow still safe enough to be looked after at home. And they're still safe enough to be looked after at home with the support that that home ward is able to provide. So we might provide oxygen, we might provide fluids, we might provide intravenous antibiotics, we could do daily blood tests, they'll get observations. they'll get seen by an experienced community matron on a daily basis, and then they're discussed with an MDT led by a consultant geriatrician on a daily basis. Then we've got access to pharmacy, social care, therapy services as required. So the kind of patients they typically look after are minor infections that still need hospital level care. Yes, they still need like a drip or an oxygen or something like that. And acute kidney injury, maybe a fall and reduced mobility, but there hasn't been major trauma. Classic deliriums where the patient's not necessarily critically unwell and might be better off in their own environment. So if you look after quite a wide range of conditions at home, just bearing in mind you don't have that kind of hour-to-hour monitoring. So typically it doesn't look after people who are like critically unwell, who need kind of regular monitoring and would be at risk of deterioration and still for kind of higher levels of intervention. It's a good option for somebody who's severely frail, who wants some treatment, but would accept that if their condition deteriorated despite that good treatment, they wouldn't want the trauma of being brought into hospital for that. So for some people, coming into hospital in itself is incredibly traumatic and stressful experience, and the home was particularly good for those kind of patients.
Thank you. Thank you for clarifying that. So I guess perhaps my last question is, I don't know if I can say this, but what is your biggest pet peeve when you're post-taking and, one of the doctors in training has clerked the patient with regards to frailty? What would you like, if I can speak on behalf of all doctors in training across the UK, what do you think we either need to do better or we need to be mindful of when assessing these patients?
Yeah, so I think on a clerking level, it's about that initial assessment. So rather than kind of saying, lives with wife, independent, or wife helps around the house, it's going to that extra level of detail to saying, actually, who does the cooking, who does the cleaning, who does the shopping, how do you walk, what help do you need with washing and dressing and meals and so on. So that's the level of detail you need to be able to describe someone's frailty. It doesn't take very long, but there is a list of about 7 or 8 questions there, depending on how frail the patient is. Then other pet peeve would be that people often miss memory problems. So people often describe somebody as, orientated or not that confused. And actually the 4ET, which is, less than 2 minutes and quite often less than 1 minute to do, is a very quick and easy way of describing that in a more accurate level. And then beyond that, I think it's just to recognize to yourself that if you do have somebody with frailty, you can't just make the standard treatment work for every one of those patients. So if I meet an 80-year-old who's fit and well, doesn't have frailty, he's got normal kidney function, normal hemoglobin, they come in with a heart attack, I'm going to be phoning you up to say, maybe you should be looking after this patient because it's fit and well, should be considered for interventions. If he wants that, should go on gelatin platelets and all the rest of the treatment. Whereas if I meet a 90-year-old who needs help getting in and out of bed and has got carers 3 times a day and their hemoglobin's 80 and their creatinine's 200, it is not a good idea to just start this person on aspirin, clopidogrel, ramipril, statin, beta blocker on day 1, because actually the likelihood is there's quite a high likelihood of causing harm just from those medications alone, and they're at a higher risk for their adverse outcomes. And we need to be thinking in a different way here. What's the treatment goals here? What's the ceiling of care? And which of these medications do the benefits outweigh the risks for, depending on what's important to that patient? So it's about kind of at the very least, just thinking to yourself, is everything required for this patient? They've got greater frailty, greater risk of harm.
And my very last question now, if you could pick a frailty score to be used, because you mentioned the different models, which frailty score do you think is perhaps easier, if I can say, for the non-specialist to use to be able to characterize frailty?
So I think it is the clinical frailty scale. So A, it is pretty easy to use, and then B, it is very widely used. So what that means is, when people get used to it, you can have a quick idea of what somebody's like. So if you're phoning me up and say, I've just seen this man with a clinical frailty score of 7, I've got an immediate picture of somebody who needs help washing and dressing, typically, maybe needs help getting in and out of bed, maybe needs help with mobility and meals and medications. Whereas you say, I've got somebody with a clinical frailty score of 3, I know that this person is walking around at a normal pace, doesn't seem physically slowed, and probably has, a degree of robustness about them. So yeah, the clinical frailty score, A, is easy, and B, because it's widely used, it's got an advantage in that it allows us to use a common language.
Okay, great. And what I'll do is put all those resources that you've spoken to me about, I'll make sure that they're in the show notes for the episode so anyone listening to us can have a read in their own time. Dr. Ninan, thank you so much for joining me today. Thank you for explaining it in a way that I'm sure all our listeners will be able to understand. And hopefully going forward, you'll see a lot more clerkings with accurate frailty measurements.